Dr. Agrawal, you're requesting a remote control of my screen. Is that correct, or was that by mistake?
Yeah, if you give it to me, yeah. Perfect.
We can start in 1 minute.
Okay.
Please go ahead and start.
Hello, everyone. Welcome to Therapeutic De-Escalation of Thyroid Malignancies webinar. This is a series of webinars hosted by the HNS Endocrine Section. I'm Nishant Agrawal from the University of Chicago, and my co-moderator is Michael Singer from Henry Ford. You know, they've been epic battles between lobectomy versus total thyroidectomy. And I think at the end of it all, we realized that everyone was correct, really depending on the context. So now, today, we'll add a few more therapeutic options, including observation for select cases. So it's my honor to introduce our discussants, Michael Tuttle from Memorial Sloan Kettering and Dr. Akira Miyachi from Kuma Hospital. So thank you, Michael and Akira. And our case presenters will be Louise Davies from Dartmouth, Dr. Lisa Orloff from Stanford, and Dr. Kendall from Tulane. I'm going to just provide some background about HNS. So HNS is the single largest organization in North America for the advancement of research and education in head and neck oncology. We have a membership of over 1,700, including 600 individuals in the endocrine surgery section. You will get a link for CME at the end of this webinar, so please be on the lookout for that. And these are our disclosures from the faculty who will be presenting the webinar today. And again, this is our agenda, and we'll begin with Dr. Louise Davis's case on micropapillary thyroid cancer and observation.
Nishan, do you want me to go ahead and share my screen?
Yes, please.
Okay. You have to stop sharing first.
Yep, nice. Betty, can you stop sharing?
Okay. And let's see if this will work now. Okay. Everybody see my screen?
Yep.
Good. Okay.
Yes.
So I'm going to walk us through this case that I've changed a few identifying details to protect patient privacy. But this is Mr. C, who's a 49-year-old veteran. And he came to our office with a complaint of neck discomfort in the setting of prior neck injury due to a car accident, saying that he felt like he had swollen glands all the time, and it just didn't feel right when he swallowed. He had this awareness of his swallowing that sometimes even happened at night. These symptoms led to an ultrasound that was ordered by his primary care provider as part of his workup. All these things happened actually in another state before we met him. And this story begins way back in 2016. So at that time, when he first presented with these complaints, his history was significant for obesity, exercise-induced asthma. He had sleep apnea. He was already hypothyroid. He took thyroid hormone medication, and he had bipolar I disorder. He's had no exposure to childhood radiation of the head or neck. And while he had a strong family history of cancer, none of it was thyroid cancer. There were both a history of solid malignancy as well as hematologic malignancies.
Luis, let me just interrupt for a second. Maybe
Yeah.
I could ask our two speakers, also Luis, your perspective on this. when you ask for a history and a patient says, oh, I tons of family members with cancers, but I don't think any thyroid cancer, does that have any impact on your perspectives, on your approach, on your thoughts?
Yeah, I mean, and I'll just say quickly for me, I'm always thinking about looking for patterns that might be an MEN pattern or familial cancer pattern. That's why I go about that.
Yeah, and I think there are other hereditary things like Lynch syndrome and other things, that are not so specific to thyroid, but in the well-meaning pattern, if there are patterns, at least we think about it. And clinical genetics are so good now that if you pick up a lot of those things, there's no reason not to at least send them for a clinical genetics consult. Sometimes they'll tell them there's nothing to be done, but multiple family members with different type of cancers, particularly the hereditary ones like breast and ovarian and colon, when those start happening together, that's something I probably wouldn't have thought that much about 10 years ago, but I end up sending a good number of these guys to clinical genetics now.
Dr. Miyuchi, in Japan, does this have any kind of difference in terms of the approach there because of this family history?
I don't think there's any impact on the actual clinical practice.
Very good. All right, thanks, Dr. Davies. Please continue.
So on physical exam, the nodule that we're going to be talking about was not palpable. There certainly was muscular tension notable in the exam of the soft tissues of the neck, but otherwise it was an unremarkable examination of the neck soft tissues. Because of the throat complaints, we did a formal endoscopy in the office, a flexible nasopharyngoscopy, and found normal vocal cord function. But we did note some post-cricoid edema of the larynx, which might be consistent with undertreated or untreated laryngopharyngeal reflux, which might be some of his sensation of swallowing that he was experiencing. Let's see if I can. So this is what his exam looked like in 2016. We have 3 ultrasound views here, and the report that we had access to when I met him described this as a 7 by 6 by 5 millimeter hypoechoic thyroid nodule that was bulging the thyroid. Although it was less than a centimeter, he underwent biopsy at that time in the setting that he was in, and it was a Bethesda 3, atypical cells of uncertain significance. And he underwent a second biopsy, and this one was sent for ThyroSeq, which showed a high probability of malignancy. He was actually followed for this at his outside facility before he moved to when I first met him for about 3 years. And this was followed as a active surveillance. In 2020 is actually the first time I met him. He moved to the area and established care with a new team in my area. And somebody did a new ultrasound, and this team looked at the ultrasound and they didn't like it. They were concerned that there might be extrathyroidal spread, and he was referred to me for surgery.
So I'm just going to interrupt you for a second.
Yes, please do.
Dr. Tuttle, Dr. Miyuchi, tell me your thoughts about 2 things. First of all, in terms of the idea of active surveillance generally, based off of this patient's demographics. So an older man, does that have a significant impact on either your expectations in terms of what you would recommend to him? And then secondly, if you don't mind, I just also would be interested in hearing your comments about the impact, if any, on, say, the location of the nodule, posterior, anterior, as Luis is showing here, maybe something that's abutting the strap muscles versus something that's, say, deeper in the tracheoesophageal groove, again, whether that has any impact.
Do you want to start, Akira? You started this 20 years ago, so you have to go first.
Well, we classify the risk of the risk for active surveillance based on the location of papillary microcancer. And we classified into 3 categories: ideal, appropriate, and inappropriate. If the tumor is solitary and solitary, and I mean the one focal, and surrounded by normal thyroid tissue, it's an ideal case. This case is not the ideal case. This tumor is attaching a trachea and possibly exposing to the thyroid capsule. So, however, the form angle formed with the trachea is acute. It's not. So we think these cases are an appropriate case. We don't care about the possible capsular invasion to the anterior or lateral thyroid capsule. So in our category, this is not inappropriate. This is an appropriate case. We think we can include this case for the active surveillance.
Dr. Miyuchi, just before Dr. Tuttle comments, can you just tell us, in terms of, say, demographics of a patient, gender, age, what impact, if any, do those have on, say, the categorization of patients in terms of whether they're appropriate or inappropriate?
Well, gender is first. Most important is among the gender and the age. Age is more important. This patient, if the patient is younger than 40 years, a risk of slight progression is slightly high. And this patient is older than 40 years, but younger than 60 years. So the risk of disease progression is moderate. And well, you know, even the patients younger than 40 years show the slight disease progression than the older, middle-aged or older patients. But all of you know that the papillary thyroid cancer in young patients has an excellent prognosis. I don't care much for the slight possible progression in younger patients. So regarding the age, it's okay. And about the gender, if the women who want to have a childbearing pregnancy, and during the pregnancy, the progression of the disease is slightly higher, but the proportion of patients who had the disease progression during pregnancy was only 8%. So it's not so high.
Dr. Tuttle?
Yeah, we would agree. I mean, I think Dr. Davies shows a good case here that trying to find an ideal case in the isthmus is going to be pretty tough, right? Because the isthmus is 4 or 5 millimeters. So if you're going to think about doing active surveillance in a papillary cancer in isthmus, it should give you pause. You want to make sure that you have all those subtle features like Akira was talking about, that those acute angles, the ones that are invading have a long face to the capsule, and they have these obtuse angles. And often the capsule, it doesn't look exactly broken, but it begins to look grayish, that I describe as sort of the Pac-Man eating their way through. And so you have to be comfortable in one like this, that if there was some microscopic extrathyroid extension, you'd be okay with that. And in this location, we would be, right? Because it would be overlying strap muscles. When's the last time one of us saw a 7 millimeter papillary invade the trachea? I don't remember you guys calling me going, hey, I had a 7 millimeter, I had to scrape it off the trachea. That's just not a common scenario. You put this same lesion down in the left TE groove or the right posterior, where even a little bit of invasion through the capsule that could damage a nerve that would, in our mind, put us in an inappropriate category. So location, particularly when you get next to the edge, is going to be important. And then to Louise's point, we have 2016 from 2020, because once you buy into the fact that it's okay to watch, then the question is, when do you stop watching? What are those things? And in general, we really look at sort of 5 features. What's the size? What's the location? What's the rate of change? Doubling time, how much is it changing? Is it causing symptoms or likely to cause symptoms? And then the patient preference. So thinking through those 5 things allows you to know the majority of these in this age group are going to be able to watch, but there'll be about 10% that slowly grow. And as Akira has shown us for many years, if you take them to surgery when they start to grow, you cure them and they do just fine.
So one thing that you haven't mentioned, and I'd be interested in hearing everyone's perspective on this, is I think this patient had Thyroid, if I'm not mistaken. What about the impact? Obviously, we've become much more sophisticated in our understanding of the molecular underpinnings of these types of cancers. What makes something more aggressive? What makes something less aggressive? So one is what is your kind of consideration, and regardless of whether it's Thyroid or other molecular testing, and is there something that makes you say, oh, no, this one we ain't going to watch. This one's going to go to the operating room, even though everything else seems favorable?
Yeah. So with Dr. Fagan, we've done a hard dive into this, trying to find molecular predictors. I'm getting more and more convinced that the tumors that have those bad molecular predictors, we would never consider them for active surveillance. They have gross extrathyroid extension. They have lymph node metastasis. In this group, I often say in these papillary microcarcinomas, you're using molecular biology to find the most aggressive goldfish in the bowl. These are low-risk tumors. And trying to risk stratify the few low risks that are going to change, I think is going to be nearly impossible. The good news is you don't have to, because if they have, one of those molecular profiles that's going to make them more aggressive, they're a little bigger in 6 months. They're a little bigger in a year. They don't turn into anaplastic. They don't get out of control. So I think it's going to be really hard, even though we're still trying to find a molecular predictor that's going to trump that initial selection criteria, and would be better than just allowing it to sort of declare its growth over a year or so and be able to make a difference.
All right, Louise, you want to carry on with your slides?
Sure. So once this patient was referred to me, it's interesting, at the time that I had to talk to this patient and we had to make decisions, I actually didn't have access to the 2016 data. So we only knew that somebody thought things were changing. And so when we met in the office, we talked through the options, and I did an ultrasound myself in the office. I was not convinced that there was extracapsular spread, but I also could see that convexity of the thyroid that other people were seeing, and so I could understand the concerns. So we talked through the options. One option was to actually continue to monitor, because I said I wasn't convinced that it was spreading. And as Dr. Tuttle and Dr. Miyachi have taught us, a little bit of involvement of the strap muscles is not really a major concern as long as you know what you're going into. He didn't have any lymph nodes positive. It had an acute angle to the trachea. Another option was to remove that half of the thyroid, the left half going across the isthmus, to remove it. He was already on thyroid hormone. And so, I can't believe I would say this, but because I'm the person who's always advocating for a less is more approach, but I said, we can remove the whole thing, the whole gland. Normally we would not do that for a tumor of this size. And, we all are humbled by what our patients want and what they think is right for them. And this person chose total thyroidectomy. And so he had, a parent with multiple myeloma, a parent with an acute myelogenous leukemia, neither of which is associated with thyroid cancer, but then he had other first-degree relatives with prostate cancer, gastric cancer, breast cancer. And I thought, maybe that's not unreasonable here. Again, these are not part of a syndrome like Lynch syndrome or these other things, but this is a patient perspective. At the time of surgery, we found a small hard neoplasm. I found no connection to the overlying strap muscles. And on final pathology, we found a 5 millimeter papillary thyroid cancer with no extrathyroidal extension.
Can I ask, and whoever wants to chime in on this, regardless, and I know we're talking about a microcarcinoma, but in any patient where there's concern for thyroid cancer, tell me a little bit just technically how you try to make that determine whether there's extrathyroidal extension into those strap muscles, because we know that if you include that strap muscle into it such that that margin is negative, it really is not a big deal, but we certainly don't want to end up leaving behind a positive margin on that strap muscle. So tell me, technically, are there any pearls that we can use to say, oh, this is extending, it's not extending, oh no, this is probably thyroiditis? What do you use when you're operating?
So if I can go, so I make this decision preoperatively. So if I think it's going to the strap, I plan to do en bloc resection with the sternothyroid at least, unless it's really going into the sternohyoid. So I just plan it. So I expose the muscle and I resect the muscle superior and inferior to make sure I come lateral to the thyroid, making a piece of the strap muscle on the top of the tumor. So I don't try to examine it to see if it's going into or not. I don't have a microscope in my loops. But I just want to make a quick comment. So I'm a big fan of thyroid lobectomy because data showed that total thyroidectomy doubled the risk. If you do the expose both sides, you double the risk. It's math. And this is what the data shows. However, in this patient, if the patient has Hashimoto thyroiditis, and we have approved that the antibodies are elevated, the Netherlands trial showed that these patients eventually can benefit from the thyroidectomy because this operation can decrease the antibodies levels and these patients can feel better afterwards. So in a case like this, I think it's a good idea to do the thyroidectomy, not for the cancer purpose, but for the symptoms purpose. From the cancer standpoint, we know that Hashimoto thyroiditis might increase the risk of cancer, but usually it's not metastatic. Like multiple studies showed that you can have a small cancer with Hashimoto, but very rarely to have a metastasis to the lymph node. You might have a lot of lymphadenopathy, but it's not usually metastatic. Thank you.
If I might make just one quick comment, you were asking about other signs that you look for, and just to make a pitch for ultrasound assessment preoperatively, you can do something called sonopalpation, where you use your non-transducer holding hand to palpate the lesion and see if there's adherence with respect to the trachea in particular. It's a little more difficult with respect to the strap muscles, but you can see if there's shifting of structures with respect to each other, and that's a good way to rule out invasion or rule it in.
All right.
Thank you, Mike. Well, yeah, I think we should move on.
Yeah,
That was a great case.
Time. Yeah, that was great. So Lisa, can we maybe have you share your slides?
Sure. So how's that?
Beautiful.
So thank you to the AHNS endocrine section and all of you on this illustrious panel for allowing me to share a case that I want to also thank Dr. Leonardo Rangel for providing with me, because I am going to speak about radiofrequency ablation for papillary microcarcinoma. And this is a hot topic about which I am very interested. I am currently doing radiofrequency ablation of benign lesions and have not yet started doing these cases myself, but I'm very eager to. And so Leonardo was kind enough to share some images and data with me. So this is a 34-year-old otherwise healthy woman who was seeking evaluation and workup for infertility. And she really had no other comorbidities, was euthyroid. And this was confirmed on up-to-date thyroid function studies. But in the process of the workup, a thyroid ultrasound was performed, and lo and behold, a sub-centimeter suspicious nodule was identified in her left thyroid lobe. She had no abnormal or suspicious lymph nodes in her central or lateral neck compartments, which is important. And here's an image of this sub-centimeter, approximately 6 millimeter, hypoechoic, taller than wide, solid nodule with some abutment of, but not really extrusion through the anterior capsule into the overlying strap muscles. There does appear to be a punctate echogenic focus in this lesion, and it does have slightly irregular borders. So it was deemed a TIRADS 5 or TR5 lesion. And this was located in the anterior mid to superior thyroid lobe. So you see the transverse view on the left, the sagittal view on the right. So at this point, management options were presented to the patient, including observation alone, given the sub-centimeter size of the lesion, or to further work it up, to perform fine needle aspiration biopsy with the idea that that would lead to some intervention, even if intervention was non-intervention. But by performing fine needle aspiration, there was a possibility of determining that this was a benign lesion, which could lay it to rest. On the other hand, the concept of biopsy always holds the possibility of getting an indeterminate diagnosis, which could open a separate can of worms that we're not really going to talk about today. But if the lesion were found to be malignant, I think, although we're talking about papillary thyroid microcarcinoma today, it is important to just mention that these types of lesions could harbor medullary carcinoma, which would take us down a potentially very different pathway.
Lisa, may I interrupt for you a second? So Mike and Akira, how would you manage this patient, a 34-year-old woman with a sub-centimeter thyroid nodule?
So I used to tell these people there were two right answers. One right answer is surgery and one right answer is observation. I now tell them there's like 2.5. That third option is this thermal ablation option, which may be RFA, it may be something else, but an ablation option, either now or in the near future. So I tell them there are 3 right answers, and we'll spend the next 30 minutes trying to find the one right answer that's right for them. Thanks, Louise, you helped me do that.
So Mike, would you even recommend an FNA?
I give them the option. There are some people, I have a good number that we're following without FNA because they say, look, I don't care what it shows. Other people say, is there any chance it's benign and I never have to see you again? Sort of what Dr. Orloff was talking about. The majority I have been biopsied, and I don't know whether that's because I work at a cancer center and we do that. I think the most compelling reason to biopsy this so you don't miss a medullary. I mean, that's one of the compelling reasons. And I know Akira always felt strongly about having a biopsy for follow-up reasons. Akira, you biopsy most of them, right?
Well, in Japan, first of all, in the world, when I started active surveillance, there was no guideline on performing fine needle aspiration. So we performed fine needle aspiration for suspicious tumor as small as 3 or 4 millimeter in size. But currently in Japan, there is only one guideline that recommend doing fine needle aspiration for suspicious nodule larger than 5 millimeter in size. So currently at Kuma Hospital, we perform fine needle aspiration for suspicious nodule larger than 5 millimeter in size. And regarding concerning this patient is 34 years women and wants to become pregnancy. So it's a little bit complicated case, but well, I talk about the possibility of mild disease progression, especially she is younger than 40 years, and if during the pregnancy there might be a slight disease progression, but the risk is not so high. So generally, at Kuma Hospital, the first recommendation is active surveillance. Although we offer 2 options, active surveillance and surgery. And I personally prefer giving levothyroxine to maintain her serum TSH level in low normal half range. That's my practice.
Thank you, Kara. Sorry, Lisa, please go ahead.
No apologies. Thank you, Nishant. Those are all very important comments and part of why I mentioned some of these sort of sidelines to the pathway to determining that this particular lesion was a papillary carcinoma, but the things that we should be thinking about. And so likewise, our guidelines do suggest to not biopsy lesions smaller than a centimeter, but as Mike and Akira pointed out, we often have patients who already have had biopsies or want the biopsy, and we don't always follow the hard and fast or cut and dried recommendations of the guidelines. So this patient was presented with these options and opted for biopsy, and then opted for the half, not the one or the two, but the half that Mike mentioned, and chose to undergo radiofrequency ablation, which was artfully performed by Dr. Rangel. And these are the images of the completion of the procedure. And it's very interesting to note that a lesion that started out at 6 millimeters following radiofrequency ablation looks a lot larger. And I think the managing team and the patient need to be forewarned that things will begin to look a little worse before they look better. And the ablation was performed with a 5 millimeter active tip electrode using low energy at 20 watts in the center of the lesion, but with a thermal zone of injury that extended beyond the thyroid capsule, which was intentional in order to be sure to ablate to and beyond the edge of the malignancy. So this is a Doppler image at the completion of ablation showing absence of vascular flow. And here's an image at 1 month following ablation, which shows that there's not quite the size seen at the end of ablation, but still the zone of injury is beyond that of the original lesion. But not to despair, because by 3 months, the lesion had completely disappeared sonographically, and there was no absence or no presence of vascular flow here. So I think a beautiful result of the return to a normal looking thyroid lobe. And that's the case. And I
Lisa,
again thank Dr. Rangel. Yes.
Lisa, let me ask you a question to play devil's advocate. So we were just saying how these patients, they don't need any treatment, right? We can do active surveillance. And so now the next step is, you know what? We are going to treat you, even though we don't think you really need a treatment. We're going to treat you with this thing that I'm assuming this patient is going to continue having surveillance anyway. So to what end, what is the benefit of doing the RFA? At this point, I imagine a lot of this is research oriented, but how do you explain, or anyone else, Michael, Akira, how would you explain to the patient what you're achieving with this intervention?
So maybe I'll just start and then let the others who are discussants embellish or expand on it. But I even think it was Mike's group that originally called active surveillance deferred intervention, because you're sort of, and I think Louise also has mentioned a general dislike for the term watchful waiting, because it's as if you're just waiting for this to grow. And I think it is that concern for that small percentage of patients who will exhibit growth. And especially, as Akira said, in a young patient, the likelihood of that happening over her lifetime is greater. And so why wait for that to happen rather than put this to rest and potentially prevent complications such as lymph node metastases, as well as the psychological costs of the surveillance and the burden of those follow-up visits. You mentioned that there will be follow-up after ablation, but the intensity and the frequency will be less than that of active surveillance, which is basically indefinite.
Yeah. So, I mean, you bring up a good point, Mike. We don't want to get in the business of finding the 10% of papillary thyroid cancers in the country and thermal ablating all of them. What we've seen, because it's more than just RFA, if you look in the last 2 or 3 years, there's 800 or 900 papillary microcarcinoma patients across the world treated with some sort of thermal ablation, radiofrequency ablation, microwave ablation, laser ablation. So this is out there. What we're seeing in our hands is when we offer people active surveillance or active monitoring, about half of them say, cool, leave me alone and I'm fine. The other half want to be treated. And what we're seeing in this ablation, it's the group that want to be treated. We're not decreasing the number of people that we're accepting for active surveillance. My guys that are watching and it's stable, they're like, well, if it grows, maybe you can do this. So I think this ablation piece is going to cut into those people that want to be treated. You guys know this because how many of the patients have asked you, can you just cut out my cancer, right? That's what they ask you in clinic. And you go, well, I can't do that. So they don't want a thyroidectomy. They don't want a total, they want to be treated. In fact, the observation group, they don't want no treatment. They're just rejecting our treatment. They're treating themselves. So I think the field for this is in those people that certainly would be good candidates for observation, but they're not going to observe. They're going to want a treatment. To avoid a total thyroidectomy or a lobectomy in these kind of patients is awesome. So I think in that, I'm going to be cutting more into your guys' surgery business and not really cutting into the people that are going to follow with active surveillance.
So,
regarding the thermal ablation, it's seemingly very attractive, but one point is probably there should be a high selection for the indication, especially the location. And even the ablation might be very successful. In our experience, about 3 to 4% of the patients had showed lymph node metastasis in the lateral compartment. And in our surgical case, also after total thyroidectomy or hemithyroidectomy, quite similar number of patients show lymph node metastasis in the lateral compartment. In such cases, what would you do for the next step? One thing. The other is, you mentioned about the patient's emotional issue, worry for thyroid cancer not treated. But Louise Davis focused on this issue, and she came to Kumar Hospital and did a very nice study, questionnaire survey and interview on the patients who are on active surveillance at Kumar Hospital. And well, recently I realized that patient worry is not actually patient's worry. It's a physician's worry inflicted to patients.
Yeah, and I'd say the only other 2 or 3 little sort of caveats to this as we move from ablating benign nodules to cancer, right? As Lisa mentioned, you need a 2 or 3 millimeter margin around the cancer, right? This is not just killing out the middle of a benign nodule. To use this effectively, you're going to have to know how to do hydrodissection because so many of these live on the capsule with either saline or lidocaine, but people that do this know how to do this. It's just part of it. And the last thing I'd say is Lisa got really lucky. The ablation zone went away at 3 months. It's usually more like 6 months or a year or 24 months. But if you watch them over time, they will shrink over time. So I think it's important for folks not to be too excited if it doesn't look this beautiful at 3 months. It may take a little bit longer. But by 12 to 24 months, the ablation zone looks almost completely normal and over 90%.
One question, Mike, from the Q&A for the group is an FNA sufficient, or would you prefer a core biopsy prior to RFA?
Oh, no, an FNA is fine. I mean, we're treating something that doesn't need to be treated. So if we're treating something that doesn't need to be treated, an FNA is perfectly good.
And Lisa, 2 questions. So we don't know what the defined follow-up is after RFA. And then if subsequent surgery is necessary, how does that affect surgery?
So as you point out, this is very early in this patient's follow-up, and we don't really have longitudinal follow-up data. We're early in the course of using this, this tool for this purpose. And so I think that we are going to err on the side of being more cautious and more intensive in our follow-up early on and hopefully gather that data. But the, what was the second question?
If surgery is
necessary, yeah. anecdotal reports from surgery following RFA of benign lesions describe no increased complication rate, supposedly no increased difficulty rate. I find that a little bit hard to believe. I have not personally done surgery following a patient's ablation. I've done surgery following alcohol ablation, and I have found that to be more difficult than a de novo surgery without prior ablation. If you throw in Hashimoto's thyroiditis on top of that, it's going to add further to, some adhesions and difficulty. So I think we can't kid ourselves that there's no increased difficulty, but the word on the street is that it doesn't increase the complication rate.
I heard Dr. Tuttle is starting a operation after RFA practice. So you're welcome to send those patients to him. I'm sure.
Yeah, I personally have a very low complication rate. I don't want to put a lot of pressure on you guys, but
I know
never damaged the nerve.
Zero.
You and Dr. Taha are starting a specialty niche there at Memorial. So again, this was great. In the interest of time, we're just going to move on to our final case. Ahmad, if we can ask you to get your slides up. While Ahmad's getting them up, can I ask a question? And again, whoever wants to answer this question, which is, I would imagine that some of the people who are participating in this call are probably a little bit surprised to hear active surveillance taken as, of course, this is what we do. Many of the people on this panel are blessed to work in major institutions, major research and academic institutions. And I'm just interested to know your thoughts about pursuing these kind of ideas in either a smaller town or in a smaller practice, a private practice, how you negotiate when you don't all necessarily agree. You have a surgeon on one side and an endocrinologist on another side.
Could I actually take that one as somebody who works in a rural setting?
Please.
I work in a 60-bed hospital. I'm one of 2 surgeons who works there. I do all the thyroid stuff. And, in terms of doing active surveillance, one thing that I think we've talked about is the need to move away from this idea that you have to be so special to do active surveillance at your institution. What you need is a radiologist who knows how to read ultrasounds, and radiologists are board certified for a reason. They know how to read ultrasounds. If you want to do your own ultrasounds, that's great. But if you have a partner who's willing to do those and work with you, and an endocrinologist who's also a willing partner, you don't have to be in a tertiary or quaternary care setting to do this. So I'll stop there just to say that, you can do this. It doesn't, we're past that point now where you need to be in a super special place. You do need to follow those patients just like you would any other cancer patient. It's just like that. I'll let everybody else chime in too.
Yeah, I agree completely, Louise, because now we know what we need the radiologist to tell us, right? So we just need to communicate that with them. And it's like anything else. It's like, would you do every thyroid surgery no, there are certain ones that you'd feel comfortable following yourself. And there are other ones that'll be more borderline that either you wouldn't do with active surveillance or send someplace to have it done. So I agree totally. We don't have to have 3 ultrasonographers in the world that know how to do this at this point.
All right.
Thank you, guys. So we'll move to Ahmad's case, micropapillary cancer and lobectomy.
All right. Can you hear me?
Yep. We don't see your screen, so
So I don't know why. So I have nothing to disclose except that I'm still feeling the emotional damage after Mike Tuttle came to my institution. He was my guest, and he gave his lecture about active surveillance for low-risk thyroid cancer. And I started to recover recently. So that's a good thing.
It's been 2 years. This is a process, Ahmad. It was before the pandemic.
This is exactly how I felt after his lections. What did I do? Why is Mike Tuttle here? But I had to make immediately another talk right after to explain why all this is not really true. But so I start with this case here. So we have a 27.
Ahmad, we don't see your screen.
You don't?
No.
How about now?
Got it.
Yes,
A
perfect.
lawyer, a lawyer.
So we
Awesome.
have a 27-year-old female who is interestingly a lawyer, who was referred for surgical evaluation with the right thyroid nodule. She had no compressive symptoms. She has normal thyroid functions and no family history of thyroid cancer. So this is her nodule. And the largest diameter of the nodule is 7 millimeter. It's hypoechoic nodule. There is no calcification. It has maybe some irregular borders. It looks like intracapsular and 7 millimeter in a young 20-something female patient. So she actually, she came in with an FNA that was already done. And
Ahmad, in your practice, you get an FNA on this patient or no?
So I follow the guidelines.
Even in lawyers?
Well, I mean, like if you really, for the guidelines, actually, it's not just about the guidelines specifically say you really need to do kind of a good comprehensive neck ultrasound to make sure that there are no metastases. But if a patient maybe is a high risk with like a significant family history of thyroid cancer, and it's 9 millimeter, I'm not sure if 9 millimeter from 1 centimeter makes a huge difference. Then maybe I stick a needle in it. But this was 7 millimeter, and she came in with this FNA already. So this is what I exactly felt, what I'm gonna say if something happened to this patient. So I guess we can discuss what's next. These are few points for discussion.
Yeah. So Mike and Akira, how would you work this patient up?
At least for us, it's an ultrasound. We don't routinely CT scan all of these folks' neck with something small. You know, if she had hash and there were funny little lymph nodes, then we might do a CT scan to help clarify. We don't think the molecular testing helps us at all. If you look at papillary microcarcinomas, at least 60% are BRAF V600E, and yet most of them don't change. So size does matter. Remember, the guidelines didn't say you can't biopsy less than 1 centimeter. It said it's not required. I mean, it gives you an out. So, you know, my general set point is not to do it unless there's some good reason to do it. In a young lady like this, I would probably try to talk her out of doing anything, and I would try to just watch this, because there's a good chance, even if it's a papillary microcarcinoma, it might not change. So I'd give her the option of following with her with observation, or if she wanted to biopsy and what it was, I wouldn't push back on that.
Mike, I know you didn't mention and list active surveillance. Would you consider that based on discussion we just had?
So I have patients showing up to my office to talk about active surveillance, but obviously I'm a surgeon, and I never say no. I follow up on these patients, and I have patients that I followed up on them with a bigger tumor that they just did not want to have surgery, and eventually I will do different things, and they change their mind. So I never really say no, I'm not doing it. And if anything, they will go to Memorial. I will say, you know, go to Memorial. I'm serious about this. And one time a patient went to Memorial and saw Dr. Ashok Shaha, and he told her to go back to New Orleans, enjoy a visit in New York, and go back to New Orleans to have your surgery done there. So, I mean, as others said, I feel comfortable offering it outside a protocol if I feel that it's a small cancer. But in this case, though, maybe I wanted to go over some data, but there are some data show for microcarcinoma. If you have a BRAF, it might show differences in Mingausing data. But the reality is, if you look at other published data from active surveillance, was insufficient to stratify the risk of progression. This is what Dr. Miucci showed in his data. And also TERT mutation, despite there is a percentage, but it was not associated with progression. And the conclusion that it was actually in 0% in patients who progressed during their active surveillance. So this is what Michael said. So I do comprehensive neck ultrasound. In my practice, a lot of these people do not get a comprehensive neck ultrasound. I try to make sure I look for extrathyroid extension, but more importantly, also lymph node mets. I like this table because all the studies were from Asia comparing looking at the sensitivity for extrathyroid extension. The only studies from US was this one with a sensitivity of 25%. because we have different patients that is, obesity is really, it's not a good friend of ultrasound. So this is what I found in this patient when I ultrasound him.
So I'll tell you, this is not uncommon. Everybody thinks with papillary microcarcinomas, you never see lateral neck lymph nodes. But if you go back and look at all the sub-centimeter papillaries you've operated on, nearly 10% of them will have clinical N1B disease. We never think about those as papillary microcarcinomas, right? Because they don't really count, they're N1B disease. So it's zero surprising whatsoever that you'd see a 7 millimeter with lateral neck lymph nodes, which was Akira's point earlier. Remember he was saying we got to look in that lateral neck and do a good evaluation. So people always show me these and they always think it's a one-off case, but it's not. There's a small group, and I suspect if we looked at the molecular biology in this small group, you may find ones like in our series, the only TERT mutations we saw in papillary microcarcinomas were the ones that already had N1B disease. That's who had the 4% TERT plus BRAF, and they would have never gotten in an active surveillance program provided they had a good ultrasound like Ahmad did, right? Or, and this is to Louise's point, you don't need the world's expert ultrasonographer to find a 3 centimeter lateral neck lymph node, right? You can find that at, I don't want to say that, but whatever state Louise lives in, they'll find those things up there.
But let me ask a question, and Dr. Mayuchi, maybe you can comment on this specifically. So here there's a patient who has a clear adenopathy, but how about the idea of doing a hemithyroidectomy with a prophylactic ipsilateral central neck dissection? Does that help? Does that hurt? Does that muddy the waters in the sense that it confuses things? What would you recommend to people who are thinking about doing a hemithyroidectomy in a patient such as this?
Well, you are talking about the patient who had small papillary thyroid cancer and no lymph node metastasis. Correct. On ultrasound examination.
Correct.
I totally agree that comprehensive ultrasound examination preoperatively is very, very important. But at Kuma Hospital, or most of Japanese endocrine surgeons perform hemithyroidectomy and prophylactic central node dissection. But Ahmad showed very nice pictures of the patients, very obese patients. I totally agree. We are very lucky. Most of Japanese people are not so obese. So central node dissection is not very difficult, very easy. And most of them, we prefer performing prophylactic central node dissection because we do not want to come back to the central area. That's the reason.
Right. So that, I think that what you just said is a critical point, because there's obviously still, even though I think in the United States, at least, people have moved away from prophylactic central neck dissections more generally. But I think your point was a very important one, which is it's not that you're doing a prophylactic central neck dissection in those patients to try and upstage them. It's that there's a belief from a surgical perspective that you don't want to be back in the central neck, at least on that side, if necessary. Is that correct?
Yeah.
Yeah, it's a very common practice in Korea. All our Korean friends perform prophylactic dissection, even for indeterminate nodules, because they don't want to go back. So now we have this young patient. So I have a question, Dr. Miyushi, about the age, though. She's 27, and let's forget about the lymph node for a minute. How does that age, Dr. Miyushi, affect your planning for active surveillance in a young patient in her 20s?
Ahmad, you are talking about the young patient with microcancer. With
microcancer, no lymph node.
No lymph node metastasis. I talk with the patients, and because she's younger than 40 years, 27 years old, and so the risk of disease progression might be slightly higher. But even at the age of 20s, the risk of disease progression is less than 50%. I mean, the lifetime disease progression rate is less than 50%. That means more than half of the patient will not require surgery. So there's so the patients might choose doing surgery or might choose active surveillance. If she or he prefer active surveillance, my personal preference is giving levothyroxine to maintain the patient's serum TSS level in low normal range, not suppressed, but low normal range.
Yeah, no, I agree. We don't use the thyroid hormone suppression as long as they can keep their TSH less than 3. We're comfortable following there. In these young people, it's clearly they're going to have a little higher rate of progression, but many of them value keeping their thyroid for another 3 years or 5 years or 10 years. So when they progress, every one of them has told me, well, thanks for letting me keep it for 2 years or 3 years or 5 years. Other people use this as a bridge to a better time. They've just got their new job. They've just had their first baby. They have a bar mitzvah. They have something. They're going to retire. So a lot of my folks are not really thinking about doing this forever, but they're using it as a bridge to a better time. So sometimes in the young people, we're not always thinking about keeping it till they're 99 years old. There are other interim things that can sometimes be important.
Dr. Tuttle, so I know that we're, obviously here we're talking about microcarcinomas, but I think you guys at Memorial and I think at other institutions, they're doing active surveillance on larger cancers. And I wonder, just say, for example, the point you just made about that, we don't need to do this right now. We can do this in 6 months or a year and 2 years. What lessons have you learned from active surveillance of microcarcinomas that you've been able to apply to larger cancers?
That's a great question, Mike. So a couple of thoughts. One, you can very seldom find a nodule bigger than 1.5 or 2 centimeters that you're going to be comfortable following with observation. They're just touching the capsule too much on the front and the back. As they get around 2 centimeters, they're more likely to have lymph node metastasis. So while we certainly have some of the bigger ones that we follow, I think most of those are probably follicular variants of papillary that are 3 or 4 centimeters with no lymph node metastasis. The other thing that we've found is it doesn't make any difference whether it's 5 millimeters or 8 millimeters or 15 millimeters. They have an exponential linear growth pattern, and whatever pace they grow, that's the pace they grow. There's nothing biologic about 1 centimeter. That's the metric system. So we've had a good number of patients that need surgery, I thought, because they were 2 or 2.5 centimeters. And as you say, they refused surgery. We watched them. We did ultrasounds. And over the course of 2 or 3 years, things gradually got bigger, or they developed a lymph node metastasis, and then they would agree to have surgery. So sometimes it's just a matter of saying, I know you don't agree with me right now. Understand this is not my choice, but if I follow with you, a lot of them will gradually change their mind over time. So more similarities than there are differences, Mike.
All right, thank you.
I agree. May I comment? I agree, Tato, Michael, that the size of the tumor itself is not so very important. I think whether it metastasizes or it's enlarged, that is very important. But at the time of the diagnosis presentation, we can check the lymph node metastasis with a comprehensive ultrasound examination, but we do not know if the tumor progress or enlarge or not. The only thing is we can just closely observe. Then we know if the tumor stays small or it's enlarged. I think I don't believe gene analysis is very useful. With our data, it's not, BLF and CART was not useful.
Matt, do you want to keep going with your case?
So I decided to repeat the biopsy of both the nodule and the lymph node, and I decided to do a genetic mutation, and it was BRAF mutant, the papillary with BRAF mutation. So in this patient, she underwent a total thyroidectomy and central dissection and modified radical neck. And this is the pathology. The largest actually was multifocal disease. The largest one was 5 millimeter, and a couple of lymph nodes were positive. So I have a question, Mike, though, and Dr. Miyuchi, like when you decide to do active surveillance for a small nodule, and instead of offering thyroid lobectomy, and the patient comes back a year or two after with a lymph node met, and now they require a much bigger operation, do you feel like you missed it, or you feel it's going to happen anyway? My question is, do you feel like a lobectomy would have prevented this from progression, or you think the disease was going to progress no matter what?
Well, that is an excellent question. You are asking about the appearance of lymph node metastasis during the active surveillance. Am I correct?
Yeah, correct.
Yeah. If these patients underwent surgery at their presentation, the most likely procedure should be hemithyroidectomy with or without paratracheal lymph node dissection. I think this cannot prevent appearance of the lymph node metastasis in the lateral compartment. So these patients require second operation, completion total thyroidectomy and lymph node dissection. But anyway, it's small lymph node metastasis, so final outcome should be excellent. After the active surveillance, if the lymph node metastasis appears, these patients require total thyroidectomy and central and lateral node dissection. It's one surgery. I think one surgery is better than two surgeries, since both management has an excellent prognosis. But I don't think hemithyroidectomy prevent appearance of lymph node metastasis.
Yeah, I agree, because we even know lateral neck dissection doesn't prevent the appearance of lymph node metastasis, right? I mean, you guys are good, but you're not God. You take out everything you can see. Radioactive iodine often doesn't work in BRAF setting. It's just the difference is if we did a total thyroidectomy and a neck dissection and somebody has a lymph node recurrence, we don't feel bad. If you do a lobectomy and somebody has a lateral neck lymph node recurrence, suddenly there's something wrong with that. No, that was the natural history of that disease. So I agree with Akira. I tell these guys, if I watch and you need a lymph node dissection, but you've had one surgery instead of two. I think if you did a lobectomy up front, you'd be bringing that patient back for a lateral neck and a completion at that same time frame in the future.
Well, thank you, everyone. I think we should wrap up. We're up on the hours. I think we had a great discussion. We added additional therapeutic options to our armamentarium. So I really want to thank the audience and the panelists for a great discussion. Mike, you were saying something?
No, I just wanted to thank the panelists and our speakers, Dr. Tuttle and Dr. Miyuchi. I think just based off the questions, you see this is an incredibly important and interesting topic to people. I want to thank you for your time.
Thank you, everyone.
Thanks very much.
Thanks.
Thanks. It's great.
Great panel. Thank you.
Thank you, everyone.
Thanks, everybody.
Michael Tuttle, I love you, man. I was just
that was perfect, man. Those are great cases. That was so much fun.
Akira, it's so nice to see you.
Yeah, nice
You look
to see
great.
you.
I missed you.
I know.
Please come visit.
I'm already looking forward. I'm planning on coming in November, so I'm
Oh yes.
Yeah. So
Wait a minute. You get to go to Japan in November? What's up with that?
No,
I'm sorry.
next year.
Not this year. Next year. Next year.
Oh, what's next year?
Nothing. We're gonna hang up on you. Nothing. No. No. It's a big anniversary in
Oh yes, 90th anniversary of Kuma Hospital.
wow.
Yeah.
Congratulations.
And so Lisa and I are going to go over and spend some time with them. So we're really looking forward. It'll probably be my first international trip, since before all this went. So we're crossing our fingers.
Oh, that sounds amazing.
Yeah.
All righty, guys. Have a great night. A great morning. Thanks, Akira. Bye, my friend.
Bye.
Take care, man.
Thank you, everyone.